We do meet a number of women with hyperthyroidism in pregnancy, and this is usually Graves' disease, autoimmune hyperthyroidism. This does require enhanced monitoring in pregnancy. First of all, we need to ensure that the woman has normal thyroid hormone levels throughout pregnancy. To achieve this, they may need to take an antithyroid drug during some or all of their pregnancy, and I'll discuss that more in a moment. And the third thing we need to think about is thyroid receptor antibodies. There is transplacental passage of these TRAbs, and therefore, because they can reach baby and potentially impact on baby's thyroid, we need to check at the start of a woman's pregnancy if they have thyroid receptor antibodies, and then again, usually around the end of the second trimester, about 28 weeks in pregnancy. It's important to check for these antibodies even if your diagnosis of Graves' disease is historical and you've had definitive treatment with radioiodine or surgery. If we look at antithyroid drugs in pregnancy, women will either be taking carbimazole or propylthiouracil, PTU. Sometimes women will be on these treatments before they come to us. And the guidance is quite clear that if you are planning a pregnancy, or if you've just discovered you're pregnant and you need antithyroid drugs, PTU is the better choice. And this is because of the potential impact of these antithyroid drugs on the developing baby. So in the first trimester of pregnancy, PTU is the drug we should use. Although PTU can potentially cause some problems in baby, these are not life-limiting or significant problems which would have any impact on the baby's longer-term development and health. In contrast, carbimazole is associated with a more serious profile of congenital anomalies, and it's particularly important that we ensure developing babies are not exposed to carbimazole during the first and early second trimester of pregnancy. Once we get to 12 to 16 weeks of pregnancy, and there will be some variation region to region, we do recommend that women on PTU through the first trimester then switch to carbimazole. And this is because of the rare but serious side effect of liver problems for mums taking PTU. Serious liver problems are extremely rare, less than 1 in 10,000 women are affected, but because of the severity of the potential problem in the liver, women should be switched to carbimazole during the second trimester. Dose minimization in pregnancy is key, and the obstetricians will often work with us to ensure that the woman is only receiving the lowest dose of antithyroid drug that they require. The antithyroid drug can cross the placenta and concentrate in baby, so it's important that dose minimization is maintained until the end of pregnancy, and where possible we stop antithyroid drugs before the end of pregnancy.